Good afternoon, and thank you guys for joining us for the 7th annual Rocky Mountain Highlights in GI and Hepatology. Hope everybody had a great lunch. And we will start this afternoon by a session reviewing the latest update in therapeutic endoscopy. Please remember to enter any questions or comments or discussion points in the chat box in the Zoom, and we will have a panel discussion at the end of the session to discuss hopefully all of these questions. So to start this afternoon, it gives me great pleasure to introduce Dr. Raj Shah. Dr. Shah is a professor of medicine and the director of pancreatico-biliary endoscopy at the Anschutz Medical Campus. Dr. Shah will be talking to us this afternoon about his approach to endoscopic management of chronic pancreatitis. Dr. Shah.
Thank you, Hazem, and congratulations to a great course for you and Dr. Wieland and Dr. Patel. I've been tasked to speak on the endoscopic management of chronic pancreatitis. And when we think about the management, we relate often to the pain associated with chronic pancreatitis. And we go back to a little bit of pathophysiology on what is an integral part of fibrosis development, which is the pancreatic stellate cell, which appears to have a central role in generating pancreatic fibrosis. And when this is stimulated through autocrine or paracrine or even other external factors such as alcohol, these cells proliferate and will transform into collagen synthesizing cells, which may lead to stricturing within ducts, fibrosis within the gland, leading to some of the symptoms that we see in complications. When we think of the most common etiologies of chronic pancreatitis, alcohol is by and far the largest, but when you combine even moderate alcohol with smoking, you see a large subset of patients with chronic pancreatitis that have those two main risk factors. We're starting to get us.
Sorry to interrupt. Can you change to a presentation mode? We can see all the next slides and the notes.
Is that okay?
That's much better. Thank you, sir.
Thank you, Hazem. So the idiopathic patients are starting to get a little smaller because we're starting to do more genetic testing with respect to hereditary pancreatitis, gene SPINK1, cystic fibrosis, or other things that we consider in younger patients when we're figuring out the etiology of chronic pancreatitis. So this is a patient with a 71-year-old male with a history of daily alcohol use for 10 years, quit 12 years ago, also has had tobacco abuse. And a CT was done showing suspected hypertensive emergency and was found to have an incidental cystic dilatation of the pancreatic duct versus a cystic mass. So we started with endoscopic ultrasound, and what we see is a markedly dilated pancreatic duct on the slide to the right. And also you can see some stones here in the pancreatic duct. Can you see my arrow? Okay. So we go in, this is actually not the gallbladder. This is a conglomerate of proteinaceous debris, possibly mucin, in the duct. And there's some calcifications here within the duct, but this is the pancreatic duct. So one thing that comes to mind is, could this be IPMN or intraductal papillary mucinous neoplasm? So ERCP is performed to further evaluate. This is a dilated duct in the pancreatic duct. And pancreatoscopy is subsequently done, showing these stones, some fragments of stones, but otherwise there are no signs of IPMN. So that little conglomerate of hyperechoic material in the duct was actually just stone debris and not IPMN. So we've excluded IPMN as a potential etiology. And the reason that's important is we're finding, as we're looking, that patients who were previously thought to be idiopathic chronic calcific pancreatitis with dilated pancreatic ducts may in fact not be idiopathic, but may indeed have IPMN as an etiology for their chronic pancreatitis. So I'd keep this in mind when you're evaluating patients with chronic pancreatitis without obvious risk factors. There's an interesting study published last year in the Red Journal looking at how the phenotypic expression of chronic pancreatitis may differ based on some of the risk factors and etiology. And for example, in this cohort or cluster 1, which was predominantly inflammatory related complications that we see in alcohol related chronic pancreatitis. And you'll see ductal disruption that can lead to pleural effusions, pancreatic fistula, ascites, pseudocysts, more commonly seen in the alcohol subset. When you think of the fibrosis related complications, which is seen in the cluster 2, this is more smoking related. So pancreatic duct strictures, biliary strictures, duodenal narrowings as well. So just an interesting way to divide up some of the patients and their etiologies and how they might have higher risk for different complications. When we evaluate patients with chronic pancreatitis that are having abdominal pain, the things we want to keep in mind include things like strictures, pancreatic or biliary, main pancreatic duct stones, pseudocysts, neuropathic component to pain, biliary strictures, pancreatic cancer is also, these patients are at a higher risk for developing pancreatic cancer, about 4% of patients over 20 years. So it can be quite extensive in thinking about what's causing pain in patients with chronic pancreatitis. One of the things I'll point out is related to biliary strictures. They tend to be pretty difficult to manage endoscopically, but they can be done. They occur in about 25% of patients with chronic pancreatitis. If they're not treated, it can lead to secondary biliary cirrhosis, cholangitis. Traditionally, surgery is done. However, with the advent of fully covered metal stents, endoscopic therapies become more promising. It can reduce the number of sessions required to resolve biliary strictures, and that's been our go-to initial trial short of a surgical either resection or bypass. And thinking of sources of pain within the pancreas itself, it's important to think about what are the contributing factors that may be leading to pain, and it helps with management. So if we think about what might increase intraductal or parenchymal pressure, that can lead to pain. Sometimes that can be a pseudocyst as well. If there's inflammatory changes, acute inflammation, or if there's neural inflammation or neuropathic pain. And those are a basic way of thinking about how patients with chronic pancreatitis may be developing abdominal pain. And I often use endoscopic ultrasound to help and determine how best to manage these patients. It can help and confirm or exclude chronic pancreatitis. And also at the same time, you can assess the pancreatic duct diameter, I believe in more detail than can be done with routine CT of the abdomen and sometimes MRCP as well. And you can also look for other features such as stones within the duct. And if you see a conglomerate of calcifications in the head of the pancreas and there is not much upstream ductal dilatation in the body or tail, it's unlikely that those stones or calcifications are contributing to ductal hypertension as a source for pain. Along the cases of patients who may not have dilated ducts, we may consider a trial of pancreatic enzyme supplement to reduce episodes of pain related to eating. And CCK is in health, stimulating the pancreas to release enzymes that can help with digestion of fats, carbohydrates, and protein. In the setting of chronic pancreatitis, where there is upregulation of CCK releasing peptide, and then CCK is released in the duodenum in a higher proportion, leading to increased feedback and stimulation of the pancreas. That may potentially lead to increasing pain. So when oral enzyme therapy is provided, it may help reduce the levels of CCK feedback. However, unfortunately, although this is great in theory, there's very little data to suggest how much it benefits. And if you do consider trying it in patients, I usually give just a 1 or 2 week trial and not have the patients on it indefinitely, which a lot of patients do end up happening. It's expensive medication, and only if it's helpful in improving pain related to eating, or of course, if they truly have exocrine pancreatic insufficiency. So pancreatic stenting for strictures, if they're felt to be causing ductal hypertension, has become a fairly standard endoscopic management for patients with chronic pancreatitis. This is a 56-year-old female with idiopathic recurrent acute pancreatitis, chronic calcific pancreatitis. She had moderate alcohol and tobacco, likely the etiologies, but also genetic testing, IgG4 were also performed, which were negative. And what's circled here is a discrete stenosis in the pancreatic head, just downstream of the pancreatic genu. And you see some modest dilatation of the duct above it. So balloon dilation of the stricture is performed, followed by 7 French stent placement, which you can see here. And then on follow-up ERCP, which is the second ERCP, you see nice resolution of the stenosis in the duct. Now, most of the time, a single stent session is not going to resolve these difficult stenoses, especially in the setting of ongoing smoking or alcohol for that matter. But if they're ongoing alcohol, I tend not to ensue on or pursue endoscopic therapy unless alcohol has been stopped. This is several studies showing short and long-term follow-up of patients who have undergone pancreatic duct stenting. Some of this data is quite dated, but you can see some real giants in the ERCP world that have published some of the series, mostly European data. And one of the criticisms, I guess, is just the fact that with technology advancing and our understanding of management of strictures in general, there's really quite variable number and sizes of stents that were used in this older data. But I would note that the need for surgery was really in the 25% or under range in these patient populations. We do have some intermediate and long-term follow-up. This is a retrospective data. One is about 1,200 patients over 5 years and multi-center experience. Almost 90% of patients had significant improvement of pain, but you can see a wide range of numbers of ERCPs necessary to resolve strictures. And 25% of patients ultimately required surgery. And longer term follow-up of about only 50 patients, a longer term follow-up of about 14 or 15 years, the longest term follow-up that I'm aware of in this treatment of patients with chronic pancreatitis with strictures. What they did find is that the rate of exocrine dysfunction over 10 years seemed to be slower than previously published natural history data on chronic pancreatitis. Again, very select group of patients, small number of patients as well, but just something to think about. Sometimes patients ask us this question, and I just tell them we have limited data on whether that's true or not. However, what does seem, and it seems to stand to reason as well, is the absence of smoking will lead to a better result in resolution and reduction and recurrence of pancreatic duct stricture in the setting of chronic pancreatitis. Continued alcohol, as you might imagine, will lead to progressive endocrine and exocrine dysfunction. And randomized trials have been done of surgery versus endoscopic therapy for chronic pancreatitis. In these studies, they have been highly selective. 50% screen failure rate is pretty high. They did have 5-year follow-up data. And in the patients who did complete randomization, they saw improvement in weight gain in the patients who underwent surgery compared to those that had endoscopic stenting. And there also was improvement in the complete and partial pain relief. But this is prior to the advent of more aggressive therapy of strictures using even dual or triple pancreatic duct stenting. So keep that in mind. But this is specifically in patients who have pancreatic duct head stenoses with upstream ductal dilatation. And so it's a very select group of patients that can be eligible and also agree to randomization. Another series, a couple of series randomized only about 40 patients. They screened almost 3 times that number of patients. So again, very selective series of surgery versus endoscopic therapy for obstructive chronic pancreatitis. But again, in those patients who agreed to randomization, that failed to meet the study criteria, there's better pain relief and fewer interventions in the surgery group. And we are currently, the enrollment is closed, but there is a WallFlex self-expanding metal stent that's specifically designed for the pancreatic duct. It's not commercially available. The trial has just ended and data analysis is being done. But the diameters of the stents available for the study were 5, 6 millimeter, and also 8 millimeter. Now there are 8 millimeter fully covered metal stents that are not, that are commercially available, but it should be noted, a word of caution, that these are stents that are designed specifically for the pancreas. They had non-flare intraductal ends and flared duodenal ends so that it would help reduce the risk of inward migration of the stent and potentially, at least theoretically, reduce the chance of stent-associated stricture. So this is one patient who we had seen during the trial, had a stenosis here in the pancreatic head with upstream ductal dilatation, probably about 10 millimeters or so. Lack of filling, could this be atrophy possibly in the tail? And then a fully covered metal stent is placed, again, a study stent. And you can see it placed just upstream of the genu. And then on follow-up after metal stent removal, you can see resolution of the pancreatic head stricture here pretty nicely, some irregularity in the mid duct. But what you see is decompression of that pancreatic duct as well upstream. So I think it remains encouraging, but of course we really need to see more data and probably eventual randomized trials to see where that fits. Now, in some patients with chronic pancreatitis, severe pancreatitis, there are scenarios where you cannulate the major papilla and you see complete obstruction. And we used to think that this was pancreas divisum, but most of the time this is not congenital divisum, but what's happened is that there's a ventral duct obstruction that induces sort of flow of pancreatic juices through the minor papilla. Now, a subset of patients, a large subset of patients may have a patent accessory duct through the minor papilla. So we use that to our advantage for doing minor papilla endotherapy in those patients to decompress the duct. And in this small series between our center and Maine, we looked at this technique being successful in a large percentage of patients with clinical improvement that's fairly modest, but it remains an option, especially in those patients who are not interested in surgical decompression. This is an example of a patient who had undergone Whipple resection for recurrent acute pancreatitis leading to chronic pancreatitis. She started having recurring pancreatitis again, unfortunately. And so we see a very stenosed pancreatic jejunal anastomosis. And you can see just a pinhole that we were fortunately able to get a guide wire across and see a dilated pancreatic duct quite nicely. And this can be treated endoscopically fairly straightforward. What we do is a stricturoplasty using a combination of a needle knife and usually 3 quadrants, along with balloon dilation, and you can see improved patency following stricturoplasty. And we have some published data on this technique to manage these anastomotic strictures. And then this is an example of a, let's see if I can play this. And this is a former fellow of ours, Chetan Mittal, has helped me put this together. We had our first description of management of a pancreatic duct stricture. One of the limits with stenting is that the stents themselves can cause stent-associated stricturing. And sometimes the strictures are refractory to stenting as well. So we had thought, well, what about using laser, soft tissue laser, to do a dissection of these pancreatic duct stenoses to see if that can help improve the patency and potentially reduce the number of interventions that are required to resolve pancreatic duct strictures. So we usually go in a 3-quadrant gentle dissection from distal from upstream to downstream, and subsequently get resolution of the stricture. Let's see if I can fast forward this. But anyway, that remains a technique. So think I'll just use a couple minutes. Hazem, is that okay for describing pancreatic duct stones? So what I'd say about pancreatic stones, they're really tough, calcium carbonate. They're thought to cause pain because of increased intraductal pressure. But most of the time they require some extra methods for breaking up of stones. And that can include extracorporeal lithotripsy, meta-analysis for pancreatic stones, and SWAL shows multiple studies have been done, 27 studies so far, complete ductal clearance in about 71% of patients. So it seems like a promise, an option. But what happens sometimes is limited ability to resolve these through SWAL alone or limited access for SWAL alone, and we'll proceed with pancreatoscopy and pancreatic duct stone targeting for management of the stones, using primarily laser lithotripsy, but in some cases we'll use EHL as well. There have been a few series looking at the use of pancreatoscopy for managing intraductal stones. The series have been small thus far, but there was a multi-center series of about 110 patients that we were one of the sites involved. Hopkins was the main steering site, in which we were able to break up the stones with good results, which I'll kind of fast forward to here. It was from Gutierrez et al., about 110 patients, complete stone clearance at 90%, and there's higher technical failure if there's more than 3 stones involved. But the adverse events for this technique is quite modest and acceptable, remains a really viable option, and really first-line therapy prior to surgery, certainly, but even prior to ESWL as well. And there are several series looking at a comparison between SWAL and pancreatoscopy. And there are so far, though, no randomized controlled trials. Ductal clearance appears to be comparable between the two with a modest adverse event rate. So we're actively enrolling patients in our prospective randomized controlled trial. We're the central site here in Colorado of SWAL versus pancreatoscopy for pancreatic stone. So we're hoping that if you have patients in your practices that would be eligible, to please consider referral for that study. Lastly, celiac plexus neurolysis, or I should say celiac plexus blocks, are often used in patients who don't have a structural option to manage their pain, meaning stenting or removal of stones. And unfortunately, modest reduction in pain. It can be transient, but we can repeat these periodically for pain management. So in conclusion, I think with improvement in some of the technology, we're able to do digital pancreatoscopy, but it's really important that there's experience in cholangioscopy and therapeutic pancreatic duct stenting prior to considering pancreatoscopy in your practice. Stones that are in the head and body are impacted, can be often adequately treated and without the use of ESWL. We use laser predominantly, especially for EHL refractory pancreatic duct stones, and multiple stones will often require multiple sessions. So we discussed this with the patients up front, that it can require multiple sessions to resolve their pancreatic duct stones. Pain relief is the primary goal in the treatment of chronic pancreatitis. If the duct is dilated, consider stenting, address stones in the main pancreatic duct. And if this does not help pain, or if there's a non-dilated duct, we'll consider initiating neuromodulators, plus or minus celiac plexus block, and surgery in refractory patients. I'll leave you with this from Justice Ginsburg to Justice Scalia debating a living constitution. And she refers to Scalia's reference to the people. And she said, think of our Constitution in 1787, we the people who were part of the political community were white property owning men, very select constituency. I think the genius of our Constitution in its over 2 centuries is this notion of who counts has become ever more inclusive. We will miss you, Justice Ginsburg. And thank you very much.
Thank you, Raj, very much for a great talk as usual.